Greetings all, this is Miss Gibson. So we're going to be going over your urinary disorders. Here are your objectives. You have several types of urinary incontinence, and I know this is just going to be a quick review. You have stress, urge, overflow, functional, mixed, and total. We know that urinary incontinence is involuntary urination. It's common among older adults, more common in women than men. Let's see. Some of the causes is just relaxation of your pelvic muscles, disruption of the nervous system, some bladder disturbances, medications, strokes. Sometimes your TBIs can also cause some bladder problems. Can be acute, which just means for a short period of time. Maybe it's medication, maybe it's stress, menopause, things like that. Can be acquired, reversible or irreversible. Some risk factors is gender, age, being overweight, smokers, family history. Some neurological diseases or even diabetes put you at an increased risk of it being incontinent. And people over the age of 65 seem to be more at risk, and that's just because things begin to not work like they should. So stress incontinence, this is loss of urine due to pressure applied, like when you're lifting, coughing, sneezing. It is more common in women. Urge incontinence, this is a strong urge to void, which precipitates involuntary loss of urine. It's the most common type in our elderly population. They just can't make it to the bathroom in time. You have overflow. This is inability to empty the bladder. It leads to over distension and frequent loss of small amounts of urine. Functional results from physical, environmental, or psychosocial causes. Mixed is stress, urge, and overflow all combined. And then total is loss of all voluntary control, which causes continuous leakage of urine. All of these can lead to falls, fractures, pressure injuries, UTIs, and depression. So urinary continence, we've already talked about your assessment. Make sure you're doing a good head to toe. You're going to assess the abdomen, evaluate for bowel sounds, any kind of distension. If the patient does have like a bowel obstruction, that can hinder their ability to urinate. You want to evaluate force and character of urine. You're just going to ask, are you able to pee? Does it burn when you pee? Is it painful? Is it a lot? Is it small amounts? For women, most of the time your PCPs will inspect the external genitalias for uterine prolapse, cystocele, rectocele, which is just herniation of the bladder. Rectocele is herniation of the rectal tissues. For men, they'll inspect the urethral meatus for discharge. In male patients, they'll also do a prostate exam. Some of your diagnostic test is just a UA, post-voiding residual volume. You want it to be less than 50, which is normal. Anything over 200 is considered abnormal. You can also do IVP, which is where they do the contrast. They'll give you IV contrast and take films of your abdominal area to make sure everything is flowing correctly. Or They may do an ultrasound like a renal scan, KUB, or cystoscopy. Medical management, the main thing is we got to correct whatever's causing the issue. Could be the medicines. We may have to give a diuretic. We may have to do a thorough medication review. For stress and urge incontinence, they may get estrogen therapy, anticholinergics. Urge incontinence can be treated with the Botox injections that we talked about earlier. Surgery, they may need, if they need bladder repair, prostatectomy in case a male patient's prostate is too enlarged. They may have to get an artificial sphincter placement, which is just like a stent. I'm going to let you guys think about nursing interventions for each of those that I just went over. For urinary tract infection, this is the presence of microorganisms in a urinary system structure. It's the second most common bacterial disease. In healthy people, urine in the bladder is sterile. There should not be bacteria or other infection organisms. The urethra contains no bacteria, and if it does, it should be too few to cause an infection. If you have a lower UTI, this is the urethra as well as or it could be the bladder. Upper is kidneys. Some causes, we know that it can come through the bloodstream, can come through the kidneys. It's usually caused by bacteria, but it can be caused by viruses, fungi, or parasites. More than 85% of UTIs are caused by bacteria. E. coli is the most common. Some other common causes are just immobility, bladder obstruction, maybe from renal stones, tumors, maybe there's a stricture there, catheters, which is a biggie, those CODIs, your catheter-associated UTIs. Let's see, renal scarring, neurogenic bladder from a stroke or MI. Symptoms, frequency, urgency, burning with some dysuria, gross hematuria, nocturia. Incontinence is a biggie. Confusion in your elderly population. Some interventions. What would you do for your patients with UTI? Are you going to encourage water? Are you going to encourage them to drink cranberry juice? If you do encourage them to drink cranberry juice, what medications can they not take with cranberry juice? Or if they're on a medication, what medication would that be if it is contraindicated to drink cranberry juice? Make sure you look that up, because there is medicines that if you're taking those, you should not drink cranberry juice. Cystitis, this is just infection of your bladder or inflammation of the bladder. It is usually caused by a UTI. It's usually caused by irritants like drugs, chemicals, radiation. Some other disease disorders that might contribute to cystitis is cancers, PID or pelvic inflammatory disorders, endometriosis, Crohn's, lupus. So, urethritis, this is just inflammation of the urethra, which is the tube that carries the urine from the bladder to the outside of the body. Females are more apt to have this. It causes burning, painful urination, dysuria, can cause hematuria, can be caused by sexually transmitted infections as well. Collaborative care, there'll be some pus or pyurias, which you'll find on UAs. Anytime your patient comes in and you think that they have this urethritis, I got tongue-tied, make sure that they are getting tested for trichomonas and gonorrhea, just to rule out your STIs, as well as HIV, which is suggested by Centers for Disease Control. And if it is just inflamed and it's not infected, like there's no pus or anything like that, it will resolve on its own. And that is it. If you have any questions, please make sure you email me.